Okay, we'll carry on from medical management because the last video, medical management is not heard properly. So when we know now in the management, it is important to find out what is the underlying cause and we have to treat the underlying cause. Secondly, we have to replace the magnesium. That is the foremost thing that we have to do because we know that the magnesium is very important because it is involved in so many activities in the body. So in mild cases, we have to give them tablet, oral magnesium oxide 3 mg per day. It has to be given to the patient. In severe cases, IV administration has to be done. So where IV administration of injection magnesium sulfate will be given 10 to 40 milli equivalent. It has to be diluted in the normal saline and it has to be given. Many times when we give magnesium sulfate to the patient will end up having magnesium toxification. So in order to intoxify that, we have to give antidotes. So antidotes are medicine which will reverse the adverse effects of magnesium sulfate. So how much will we give? So now two administration, IV administration, one in the central venous line has to be done and one in the peripheral line. So calcium gluconate and calcium chloride are the two antidotes for magnesium sulfate. So calcium chloride has to be given of about 1000 mg or 13.6 milli equivalent of calcium can be given through central venous line. So usually I have told you many times, central venous line will be in the neckline, which is a jugular line, or it will be here, jugular vein, internal jugular vein, or near the heart, which is a cephalic vein. So in that we have to give the calcium chloride, and then calcium gluconate has to be given through peripheral IV line. Normal IV line we have to give calcium gluconate, which is about 1 to 3 grams has to be given. That is 4.56 to 13.7 milli equivalent of element calcium can be given. So when we give calcium chloride, it is to be given for 10 minutes. Slowly you have to give. And when we are giving calcium calcium gluconate in the IV line, you have to give within 3 to 10 minutes. Okay, so this is about the medical management. Next, going to nursing care of hypomagnesemia. So what are the other things that we have to remember? So it is monitor bowel sounds and abdominal distension. You have to check first, assess the condition of the patient, check the vital signs, then you'll have to check the bowel sounds, if there is bowel sounds, presence of bowel sound or abdominal distension. In case of any fluid collection, you can check the abdominal girth of the patient. Then monitor serum magnesium level has to be checked, calcium levels has to be checked. Make sure that you check the ECG, see for any ECG changes, like we've already seen QV intervals has to be checked, QT intervals, prolonged PR will be there, ST segment depression will be there, flattened T wave will be there, and then prominent U wave will be there. Usually U wave will not be seen, but here it will be prominent. Check all those changes, and prior to magnesium infusion, check reflexes of the patient. So usually when we give magnesium, you should always check the reflexes, biceps, triceps, Achilles tendon, knee reflex. You have to check to see if the reflexes are present or if it is suppressed. If it is suppressed, it means that the patient is into magnesium intoxication. Urine output also will be affected. So you have to check these, and then only you should give the next dose of magnesium sulfate. Then provide calm and quiet room for the patient, because the patient can also end up having seizures. Make sure that you take precautionary methods and put the side rails of the patient and keep the patient safe. Okay, so these are the nursing care that is provided for hypomagnesemia. Okay, then until we meet again for the next class, we will see in the next class hypermagnesemia and the other underlying conditions. Okay, then take notes. Any doubts, please post it and ask your coordinator to inform to me, so I will give you further clarification. Until then, bye.